Good morning, everyone. My name is Dr. Marah. I'm a general fellow at UT Health Science Center here in Houston, so I have some home court advantage. Welcome to Houston, and thank you for having me. The case I'm presenting today titles Embolisms with TandemHeart Support. So this is a 64-year-old Hispanic male originally from El Salvador. Medical histories included AFib, had an ablation in 2010, also has hypertension. He is the breadwinner of his family, had 3 kids, was fully functional, played soccer on weekends. His story started off at an outside hospital. He presented with typical angina with associated diaphoresis and dyspnea. EKG on admission showed that he had pretty typical convex ST elevations in his inferior leads with posterior wall involvement. His immediate course was complicated by sinus bradycardia and VFib arrest. Hemodynamic stability was restored after cardioversion, and he was started on antiarrhythmic therapy. He was rushed to the cath lab, had a selective coronary, which was remarkable for occlusive mid-RCA disease with TIMI2 flow post-revascularization. Baseline echo showed that his EF was 45%. He had akinetic inferior wall segments. Within 24 hours of being in their CCU, he started to demonstrate signs of hemodynamic compromise and multi-organ dysfunction. He had elevated liver enzymes, he had acidemia, he also had renal insufficiency. Repeat echo at the time showed that he had developed a 1.5 centimeter inferior posterior muscular VSD with left to right shunting. EKG did show resolution of the SC segments to the isoelectric baseline with pathological keyway in inferior leads. The following interventions occurred over the next 12 hours. Inotropic support was started, and repeat selective angiogram showed 100% mid-RCA in-stent thrombosis. At this point, the interventionalists were unsure if this was due to biological or mechanical or even technical factors. The right heart cath was performed, showed that his right atrial pressure was 15, his mean PA pressure was 35, wedge was 19, and his index was 1.6. So a balloon pump was placed with improved hemodynamics, and a consensus decision was made to transfer to a higher level center for consideration for VSD repair. After transfer, the patient was seen by the heart team and had a thorough evaluation. The plan at the time was to observe over the next 10 to 14 days. And the rationale here, I believe, was to allow for myocardial maturation given tissue friability during this early post-inflammatory period. A defect of 1.6 centimeters, which was what was measured on the last echo, was at the crossroads of candidacy for percutaneous versus surgical closure. However, the interventionalists reasoned that its inferior posterior location leaves little rim to secure a device percutaneously. So we watched with serial TTEs every day, sometimes twice a day, and we waited. We watched and waited some more. He remained stable on minimal inotropic support with a preserved mental status and improved end organ perfusion. The managing team understood that there was data suggesting improved outcomes with delayed intervention, and this was thought to be related to evolution of the infarct and improved stability of the cardiac tissue, or maybe just representation of a survival bias, as early surgery is usually performed on individuals with marked instability and circulatory compromise. So we watched, and we waited some more. 2 stable weeks later, he acutely decompensates with profound hypertension, worsened acidosis, elevated transaminases, and multiple runs of non-sustained VT, which is localized to the RV. Rapid escalation of pressor support and balloon pump failed to demonstrate any hemodynamic benefit. Repeat echo showed a 2 centimeter aneurysm in the basal inferior wall and worse than pulmonary to systemic blood flow, indicating an increase in the left to right shunt. At this point, a decision was made for TandemHeart cannulation in order to decompress the LV and reduce the work of the heart. A 21 French inflow cannula was placed transeptally into the left atrium, and a 17 French outflow cannula was positioned as RFA at aortic bifurcation. At a speed of 5,000 RPMs, the AV appeared closed. And so the speed was decreased and the patient was started on dopamine. Our patient all of a sudden became unresponsive to both verbal and painful stimuli with hypoxic respiratory failure requiring emergent endotracheal intubation. The initial CT brain showed a questionable right caudate infarct. Repeat CT brain 4 hours later showed the interval development of multifocal linear air densities within bilateral cerebral sulcal spaces. His neurological examination was notable for corneal response asymmetry, dysconjugate gaze, ptosis, absence of cough, and no movement in his extremities. The stroke team saw the patient, and based on their evaluation and the clinical picture, they suggested this was signs of severe brainstem injury features. So this was a recording from bedside device interrogation. Obviously, permission for reproduction of this video was obtained from the family, and care was taken to omit all patient identifiers. And this is video courtesy of one of my attendings, Dr. Bindo Akanti. As you can see here, I don't know if you can see it very well, but you can see a lot of air bubbles going through the system. And this is obviously a closed-loop system, and this is coming from the 21 French inflow cannula. So of course we had a lot of questions. How did this happen? What can we do? Not that the situation can be any more dire. The final echo showed a large echogenic mass measuring about 3.7 by 3.7 centimeters on the right atrial side of the interatrial septum. This was consistent with the thrombus. At this time, all mechanical circulatory devices were in full support, and patient was maximized on vasopressors and now had no meaningful neurological response. So a bit about TandemHeart VAD. TandemHeart, first described by TL and colleagues in 18 patients with acute MI complicated by cardiogenic shock, resulted in significant improvement in cardiac index from 1.7 to 2.4. There was also increase in mean arterial pressures from 63 to 80 and decreased filling pressures. Yes, it gained FDA approval in 2003. Its benefits are without question. However, the potential complications could be catastrophic. Percutaneous placement requires experienced operators familiar with the technique of transeptal puncture. In our case, it appeared that our patient suffered from pneumocephalus, presumed secondary to significant air introduction to the closed-loop system upon device implantation. I'm sure most of us in this room know the steps for implantation of a TandemHeart. Now, where in this stepwise process did we go wrong? Now, you do femoral artery cannulation first with pre-closure with perclosed devices, and then femoral vein cannulation, followed by transeptal puncture with a Brocken-Braun needle and Mullen sheath. The Mullen sheath is an exchange for 14 French, 21 French, two-stage dilator over 0.038 amplats super stiff wire. The position of the cannula in the left atrium is confirmed by injecting dye and drawing blood and assessing the level of saturation. Care must be taken to place all side holes of the TandemHeart cannula into the left atrium to avoid possible right to left shunting during device operation. The transeptal cannula is attached to the inflow port of the centrifugal blood pump in the standard wet-to-wet fashion with a 3x8 in-Tigan tubing. The femoral artery cannula is similarly connected to the outflow conduit of the TandemHeart pump. Now, sorry, that kind of went kind of fast. So a bit about pneumocephalus. Pneumocephalus is rare but potentially fatal occurrence from procedure and clinical scenarios. It is not well understood or well reported in contemporary literature. Unfortunately, it seems like I said, there's little to go by to explain how these events happen. From our side, I would rather leave it up to the surgeons to see exactly their experiences with air embolisms in the setting of TandemHeart insertion. But The symptoms that these patients do present with normally include neurological dysfunction, confusion, seizures, stroke. Management, unfortunately, there's not much to go by. Once these patients have this level of air emboli, its prognosis is almost always poor. Thank you very much, and I'll leave it to discussion with the panel.
So that's an excellent presentation. You know, I think the two places we frequently see the air is in the de-airing that you were discussing, and then what you didn't highlight was the step right after, which is the wet-to-wet insertion. Now, based on that one little picture, that didn't look like that happened there. That looked like a wet slushy, and you know, you would think that if it was a single air gap in the insertion of the device, that you would have actually eventually cleared that through the lungs or some other place, that you wouldn't have continued to get that dramatic amount of air in his head, which would make me think that somewhere there was a leak in the circuit, a hole in the tubing that you couldn't see, or in the connection of the cannulas. It's just too much air.
I would say that I agree that it's not closed in a sense because it's LA to FA. So maybe you're in training air. However, if there was a clot somewhere in the left atrium, for example, the device just pulls. So you might entrain air some way like that. But yeah, I agree, it can't be. We've all seen cases where there's a small bubble, and usually if you see a bubble, you just get it out before you start the machine. But I'm not sure.
It's an excellent case for teaching. I would like to go back a little bit before the air, because we are dealing with VSD. In fact, VSD is usually a problem to the right heart. We are adding load to the right heart, and also right heart problem, not the left heart. In our selection of the devices, we have to pay attention to this. Probably TandemHeart, in this case, not the best appropriate approach to patient having, in fact, VSD, because you are now confronting the right heart with severe increase in the volume, increases the pressure. Right heart is going to fail. Either it's going to be right heart in ECMO, and you have the shunt because you are loading the left ventricle excellently with the VSD. That no need to get unloading. That's a great case for ECMO. That's number one. Number two is the cardiac index is useless in such kind of condition. If you're measuring that with the thermodilution, you have to go with the oximetry and in a superior vena cava, and not that to help you to guide your therapy on those patients. The air, I agree with the air problem we have in the system.
What was the rationale? I mean, I know, you know, you all are fortunate enough to have everything here, so you can be very sophisticated in the selection of your devices. Why did you all pick a...
I would respond that your comment, but I think Dr. Carr is in the
No, go ahead.
No,
I'll talk.
you do.
Okay. Now, first thing, you know, physiologically, when you see a VSD, it's obviously a load to the RV. LV on echocardiography looks very good because it's dumping to a low pressure chamber, but the LV is hit big time. Anytime you close the RV, you see the LV is the one which struggles. So unloading the VSD and decreasing the left to right shunt, you will try to protect the right ventricle. So if you upstream take the blood from the left atrium, you are causing less left end diastolic volume or systolic volume in the ventricle, thereby decreasing the left to right shunt, which is the problem, which is causing the RV problem. Yeah. And we have proven this hypothesis because the largest series in VSD strategy, as you know, VSD medical management and surgical management has mortality in excess of 60 to 70%. Even in the shock trial, it had an 88% mortality when surgery was done. So what we do routinely as a protocol is we bring the patient and do a tandem heart in a patient who's hemodynamically unstable. This guy was stable for a long time, so he had balloon pump. And then give them about 7 to 10 days for the tissues to mature. 8 out of 10 we can percutaneously close, and they have had very good results. And the few others, the surgeons have had a very good time repairing because the tissues are now scarred. So our result, in fact, the paper we published, our survival is 80%, not mortality, doing this strategy. So as a result, this is the protocol we follow. Now, where does air come from? I agree with David. There must have been a micro hole somewhere in the system which was sucking. When you see a Coca-Cola or a fuzz of a soda on your tube, you know it's a continuous air leak. It's not one bubble which got in. And if you see that picture which was taken was not at the time of insertion. This was in the ICU. So there are two places where tandem heart can cause a problem. One is when you do antegrade stick, where you connect the plastic tubings, there could be a crack. It is very fragile. If there is even a small crack in where you screw it very tight, you may have a leak there and have something like this. And the location would suggest probably that's what happened here. But the other place is when in an extreme situation you're preparing the pump, the housing, if you see the lubrication system of the tandem heart, it is the casing where the heparin and the blood mixes, because there is a heparin line, and that has to be de-aired absolutely meticulously, and you've got to get time to do that. In a rush, if you don't do that, I call it the death crunch. If you put your ear next to the tandem heart, you will hear a crunching sound. That means there are bubbles of air which is being circulating, and you can hear it. I don't know whether that happened in this case, because that is the other time I have seen when this foam thing keeps coming from the pump itself. But since we did not see coming it out in the outflow, but we saw it at the connection where you saw the foam, I agree with you that there probably was a crack there. As a result, this thing was being sucked.
I just want to congratulate the team here on that physiology. I'm going to look up that paper, and I would say that Burkhoff, why does Burkhoff leave when the most important, potentially, part of the conference is here? Because I think he should simulate that for all of us. So what you've shown is exactly what a baby goes through when they have a VSD. The load is on the LV initially. And the only reason they're out of heart failure, it's not the pediatric cardiologist who do a beautiful job. It's the PVR going up that clamps the LV loading. And that's beautiful. So the survival is 80% with an ischemic VSD in shock or not in shock?
Shock.
Wow. I mean, a lot of them are in shock, but
shock.
Yeah.
guidelines.
No, there's a paper, to be fair, from an Italian group in Milan presented with Impella as well, and Enrique may know that group. They had a very good survival also. I think it was 68 to 70%. But for the reasons of the perforation that you saw in the previous presentation, we are a little nervous to put an Impella in a necrotic tissue. When, in fact, in TCT, I think it was Samir who was presenting, or Oman, I forgot who, was exactly a similar case, inferior-posterior MI, and they put an Impella, and third post-op, they had a perforation for the
I just want
Impella.
to make just one comment. Before this case I heard, I haven't had another one, but 8 years ago when I first arrived at HUP, we had a woman that came into the CCU exactly with this picture, with the balloon pump causing very unstable shunting and unstable hemodynamics. And I told her that I was going to pray for her as Dr. Wu took her to the OR at 5 or 6. I was very honest with her. She's a very religious woman and a councilwoman in Philadelphia who still sees me 8 years later. But what Joe did is she had to go to the OR because she had a VSD, but also partial rupture through the posterior wall. So she may have died had we not done that. We just
So
got
the
lucky.
Impella group presented a decent number, but again, the risk of perforation. And I think theoretically there's a concern that you're sucking from the left ventricle right adjacent to a hole in the right, so risk of paradoxical embolism probably would be higher. No one has reported that, but I would think, because if you see the evolution in our series we showed, at the time the VSD grows by about 40 to 50% in about a week's time, because the necrotic tissue keeps falling off and I don't know where it goes. And that's what, if you have an Impella sitting next to it, I don't know where it's going to go.
A couple of things. We don't take the tandem out if they go for VSD repair. That tells the point that the LV is still struggling. If you take the tandem out right away after the closure, the LV will fail. So our protocol is very clear. If it's surgical or percutaneous, we don't take out the LV support right away. Wait for the LV to recover.
It's really quite eloquent. Thank you for the explanation.
Okay, a question about the neurocritical care management for this patient. I was wondering if there was any discussion about how hyperbaric management, because if I'm not wrong, you guys have a multi-place chamber at Memorial Hermann.
We do. There was a discussion amongst the teams, but the concerns were the patient had indwelling mechanical devices. And at that point, they said, well, it doesn't make sense to, it's not feasible to take this patient for hyperbaric oxygen therapy. And also, patient had multi-organ dysfunction, DIC, absolutely no neurological response. And we had a pretty thorough discussion with the family that this was at the end of it, so.
And one other question, because this is, it happened in our center where we had an air embolism as well in a patient with mechanical circulatory support. The question is to the panel, have anyone heard of like the safety of using, putting ECMO machines or tandem heart machines in the hyperbaric chambers? Because this is, seems that it happens and sometimes that's the only possible salvage therapy from a neurocritical care prospect?
For that reason, I think you need to reverse you need to do a retrograde cerebral perfusion and then hyperbaric. Hyperbaric by itself I don't think it will helpful because it's air and it's still in the brain. And in this critical condition, doing the retrograde cerebral perfusion it will be really complicated, I guess.
First need for doing hyperbaric is he has to be hemodynamically stable. You cannot take a hemodynamically unstable, put it in a chamber. And one of the weakest problems, the Achilles heel of tandem heart, is once you put a tandem heart, you don't even want the patient to poop. Because if he moves a little left or right, that cannula is going to come out. It's not secured. So moving that patient, even for a CT scan, is a nightmare, leave alone going to hyperbaric. But it's a good suggestion. If it's a stable patient, like for some other reason, I think that's something you can do. That's why the neuro guys do it, and they're successful because their patients are usually hemodynamically stable, but these group of patients are just too sick.
Do we know if the 3/8 tubing can tolerate a certain pressure for the hyperbaric tube?
That's what I don't know.
That's also something to consider.
All right, thank you very much.